Okay, so I think we're actually live already. So
Yes.
good morning, good afternoon, good evening, everyone. Welcome to this session 13.1 on child health and nutrition. My name is Kerry Albright. I'm currently Deputy Director ad interim at UNICEF's Office of Research in Innocenti, based in Florence, Italy. And it's my pleasure to chair this panel today. We were going to have three speakers, but unfortunately one has been unable to attend. So we're joined today by Monica Jain and by Hugh Sharma Waddington. So before I hand over to Monica to get us started on the first presentation, let me give you a little bit of background information about her. So for those who don't know her already, Monica works as a lead evaluation specialist at the International Initiative for Impact Evaluation, or 3IE, where she manages a global portfolio of policy-relevant impact evaluations focused on immunization and SDG-informed sectors. Her work involves reviewing and quality assuring 3IE-funded research, as well as leading in-house synthesis and evidence gap map research. She's a member of the WHO working group to measure the drivers of vaccination uptake. She's also a development economist with more than 15 years of experience in the area of evidence-based policies. Before joining 3IE, she worked at IFPRI, the International Food Policy Research Institute, on food and nutrition security policy issues, and also at the World Bank's Poverty Reduction and Economic Management Unit, where she worked on policy-relevant poverty research and statistical system strengthening of the Indian central and state governments. So very interesting background. And today she's going to be talking to us about the use of community engagement to improve child immunization in low and middle income countries and sharing some findings from a systematic review. Monica, thanks very much. Over to you. You've got about 15 minutes.
Thanks a lot, Kerry. I'll share my screen now. I'm just told to share the entire screen. So Kerry, okay, great. Thanks again. So as Kerry has just said, that I would be talking about a systematic review that we have been working on, which looks at the effectiveness of community engagement interventions to improve immunization outcomes in LMICs. Before that, I'll just give you a brief introduction to International Initiative for Impact Initiative. Impact, and that's 3IE. We are a member-based international NGO promoting evidence-informed development policies and programs. We also support production and synthesis of contextually relevant high-quality evidence, and we do so by extensively engaging with a range of stakeholders throughout the course of the study. So as far as the systematic review is concerned, there were three main objectives of the systematic review. One is to understand whether community engagement interventions improve routine immunization outcomes of children, and our population is basically limited to low and middle income countries. We also wanted to understand how and why the interventions are working or not working. The third main objective was we wanted to understand the cost effectiveness of these interventions to improve the outcomes. So the first thing we had to do when we started our systematic review is to define community. So for us, in our systematic review, the way we have defined it is a group of people who are basically served by a particular primary health facility which provides immunization services to the children. So it could be a Kebele in Ethiopia, a ward in Nigeria, a subcenter in India. And it also encompasses a very wide range of stakeholders, from caregivers to frontline health service providers to influential community members such as religious or other traditional leaders. We also developed a community engagement framework. And based on what we saw in the literature on the real-world interventions that have been implemented across the low and middle income countries, we found that they could be broadly categorized into three kinds based on the process of engagement. That is, when and how the community is engaged. So the community could be engaged in the design of the intervention. It could actually, the engagement can occur in the implementation of the intervention. And then what we also found was the intervention itself may be the engagement. So for the type of engagement intervention design, here the community input or feedback was sought before the implementation of the intervention, and this was sought, either in the form of a pilot, a needs assessment, a formative evaluation, or it could be some other outreach efforts. Some examples are, we found that the community was consulted on if the incentives were supposed to be given, what should be the form of incentive? Should it be oil? Should it be food, grains, or should it be mobile recharges? It could also
Monica,
be this. Yes,
sorry to
sorry.
interrupt. We've actually had somebody who's saying that, can you put the slides on slideshow so we're bigger, so they're a bit bigger? We can't actually see full screen, if that's possible.
Are you able to? Are you able to see my notes
We
itself? It
are,
seems.
we are.
Oh, okay. Sorry. Okay. Uh, that's the problem because I was on the. Sorry. Okay. Okay.
Better.
Okay.
Thank you.
So this is better. Okay. So and the community, so that was, so incentives, it could be the community input was sought, for both the form and the size of incentives. Then there were community input was also sought in designing reminders, like those were very common interventions. So what is the content of the reminders? What is the language of the reminders? What is the mode of the reminders? So community was engaged in that. Community was also engaged. That's the second type, is the implementation. That is where the community members were involved in the implementation. And what we added to that was that they should have an opportunity to affect or influence its implementation. The example would be that the community is actually involved in monitoring of project implementation or the health facilities themselves, or the community leaders are actually involved in outreach activities and defaulter tracing. The third type is where engagement is the intervention. That is when community interventions themselves make a serious attempt to gain community support, or they can actually motivate communities to take ownership of service delivery. Now, over here, the examples are that basically what we saw was creation of community-based cadres. It could be in the form of village health committees, or it could be in the form of community groups such as community health workers or women's self-help groups. In our systematic review, we have 61 studies included, and if we look at the studies by the breakdown of the type of engagement, the biggest one is the intervention as the engagement type. So we have 27 studies for that, and then there are 16 studies where community was engaged in the design of the intervention, and 5 studies in the implementation autonomy, where they had some autonomy to influence the implementation. And there were 15 studies which were a combination of these three types. It could be intervention as engagement plus engagement in design, or intervention as engagement plus engagement in implementation, or other permutations. If we look at the studies, distribution of studies by geography, there was a major chunk, which is almost half the database, evidence base, which was from South Asia. And India had the biggest number of studies in South Asia. And then we also had another big chunk of studies which are coming from Africa. And over here, Nigeria had the maximum number of studies. We also had some sprinkling from Latin America as well as Indonesia from Southeast Asia. The primary outcomes that we looked at for our systematic review were full immunization coverage, DPT3 coverage or Penta3 coverage, measles coverage, and then timeliness of all these immunization outcomes. The quantitative approach that we took was we basically did the effect size data extraction. Then we did a meta-analysis of these effect sizes, and we used the random effects model. To assess the heterogeneity of the effects, we also did the moderator analysis. We also assessed the quality, the quantitative quality of the studies for both the experimental designs as well as the quasi-experimental designs. As far as our qualitative analysis approach is concerned, we wanted to understand, as I mentioned, how and why interventions are working. So we wanted to understand the context, the design, as well as the implementation of these interventions. So we looked for additional documentations connected to the studies. So we looked at qualitative studies, feasibility studies, stakeholder analysis, everything, anything that was associated with the study, we searched for it. And we coded all the documentation that we found on NVivo. And from there, after the coding, we did a thematic analysis, and also, we did the constructed the hierarchy charts. In addition, we also did the critical appraisal of all the qualitative studies. We also, as I said, we also looked at the cost effectiveness analysis. We carried that out. And for that, most studies had very limited information on cost. So we wanted to make sure that we are inclusive. So we actually did an outreach to all the authors of the 61 studies and requested for any additional cost evidence, and we got some. Then we extracted all the data related to cost. And then we, of course, synthesized it. And we also did a risk of bias in cost effectiveness estimates. So now this is the summary of our quantitative results. In the rows, we have the outcomes for full immunization, measles, DPT3, and the timeliness. And the columns are the intervention types. So the first column is when we put together all the intervention types together. And then I think the last four are, the various engagement types that I had just described to you earlier. So what we found was that if we took all the community engagement interventions together, whether it is full immunization, whether measles, DPTV, or timeliness, for all our primary outcomes, we find positive and significant impact of community engagement interventions. When we look at, by the type, so when we take the engagement as the intervention, we find that it has a positive and significant impact on all the coverage outcomes, and we didn't have sufficient studies to actually assess its effectiveness on the timeliness outcomes. For the engagement in the design, we found positive and significant impact on full immunization and measles coverage, but not on DPT3. And we also found positive and significant impact on timeliness of DPT3 and full immunization. For engagement in the implementation, we did not find any significant impact for any, on any of the outcomes. For multiple engagement types, we found a positive and significant impact on DPT3 coverage rates. Now I'll go on to describing what we found on our qualitative results, like what are the underlying factors which were associated with intervention success or failure, and they fall into the three broad categories. First is the contextual factors. We found the contextual factors, not surprisingly, they act as both barriers or enablers in an intervention. And if the interventions did not take full cognizance or even partial cognizance of the contextual factors, they tended to fail. Some common contextual barriers that we found included cost, and that was the mostly non-vaccine cost. So it was like opportunity cost, like the time it takes, take a child to an immunization center and get that child vaccinated, or the transport cost, the logistics, how far was the immunization center, what was the availability of the services in that immunization center. And those were associated, those barriers, if it was limited availability, it was too far away, that was associated with a barrier to immunization uptake. Then I think we also found, interestingly, the enablers. Positive caregiver perception of immunization or the or there were good availability of health services, we also saw those as enablers to immunization uptake and the intervention uptake. We also looked at, what are the design features that are associated with the success or failure of an intervention. And we found that community engagement features themselves were associated with intervention success. And that would be stakeholder consultation, community dialogues. We found those were associated with intervention success. Also, involvement of community leaders we found to be associated with intervention success. Besides community engagement features, we also found non-engagement features, such as, if you give incentives to caregivers, if health workers have leadership and, supportive supervision, they also were found to be associated with intervention success. The features which were associated with intervention failure were like if they did not have adequate duration, like so the intervention did not run, for a very short time, or the exposure to intervention was not adequate. Those were associated with intervention failure. We also looked at the implementation factors which were associated with success or failure. And not surprisingly, again, like low fidelity. If the implementation did not go according to the plan, that was, a low fidelity of the intervention was just failure. Also, again, not surprising, if you interventions, and it was interesting that we found it was, prevalent that if the interventions did not properly account for realities on the ground, if the intervention was based on internet or was on cell phones, sending messages, and if there was not a proper internet service or the cell phone service, then not surprisingly, the interventions failed. And we did get that, as we, that was if we did not properly account for realities on the ground. It could also be due to, deteriorating contextual factors like political insecurity. Like we did find in one study, because there was an emergency in Ethiopia, so they actually could not implement part of the intervention that they had planned. So that also resulted in failure of the interventions. There were administrative challenges, which were common. I've already talked about the technical challenges, like, not having the right infrastructure on the ground, from political challenges to staffing. Like, there's some interventions where they mentioned that, there was not adequate staffing. So that was associated with the intervention failure. On the cost effectiveness, what we found was that the median non-vaccine cost per dose of intervention to increase immunization coverage by 1% average around USD to $2.3. And there was a range of cost effectiveness estimates. They basically varied from $0.31 to a max of like $30. And there was another study which was just above and beyond the range that we have. And so we did not include it into the figure, but of course we have those figures in our report. Sorry. Sorry, somehow. Okay, yeah. So the last slide is that, so what are the implications for policy and practice? So what we found was that, community engagement interventions have a positive effect on all the primary immunization outcomes. So our first conclusion is that, they are an effective, they should be considered an effective tool to improve immunization outcomes of children in low and middle income countries. The other implications for policy that we have is that the appropriate intervention design, that is including building in community engagement features or even non-community engagement features, can lead to intervention success. Of course, not surprising, addressing common contextual barriers of immunization and leveraging facilitators are likely to be useful in designing new interventions. Also, I think it is very important. I think what we found was that important implementation preconditions, such as regular internet service service or sufficient staffing should be assessed and established before the implementation, so that it should be considered during the design stage itself or through the design itself. Like in one study, they actually used community engagement to improve the delivery of services. So that could also be possible, but those considerations have to be given, before the implementation happened and not an afterthought. And then the last was that some community engagement interventions, it was noted that they require more time or more significant time to improve outcomes. So they need to be implemented for a longer time. That's it from my side. I really look forward to the comments, the questions, as well as the feedback of the participants in this panel. Thank you.
Thank you very much, Monica. There are no questions at the moment, but I propose that we move to Hugh straight away. But please, colleagues who are listening, do type any questions that you have for Monica, a really interesting presentation, either in the chat or in the Q&A. Thanks for stopping sharing, Monica. Whilst we wait for questions to come in, let's move to our second speaker, who again probably needs no introduction to many of you. So Hugh Sharma Waddington specializes in policy research on topics like water, sanitation and hygiene, or WASH, on governance and agriculture, using methods like impact evaluation, systematic reviews and meta-analysis. He set up 3IE's Systematics Review Programme and the London office at the London International Development Centre, and is also the founding editor and a former co-chair of the Campbell Collaboration's International Development Coordinating Group. Prior to that, he's worked in the government of Rwanda, at the World Bank and at the UK National Audit Office. And now he's currently assistant professor at the Environmental Health Group of the London School of Hygiene and Tropical Medicine. He holds advanced degrees in development economics and in environmental health. And today he's going to be talking to us about using trial reports to conduct a rigorous and relevant statistical synthesis, sharing evidence from a meta-analysis of mortality. Hugh, over to you, about 15-20 minutes, please.
Okay, thanks, Kerry. Thanks, Monica. I'm delighted to be here, and I hope you can now see my slides. I can't see you, so you can't give me a thumbs up.
We can, Hugh. Yeah, we can see it full screen.
Right. Okay. Great. Okay. So this is as Kerry's indicated, I'm going to be presenting a meta-analysis of mortality relating to water, sanitation and hygiene, or WASH. But there's a broader message from my presentation, which is how we can use meta-analysis to go above and beyond what is reported in studies, typically, particularly including trials, and what types of information trials need to report in order for this kind of work, which can potentially save thousands of lives in terms of its policy implications. So I'd like to also acknowledge my co-authors, who are Sarah Bick and Sandeep Cairncross. They're both also based at the Environmental Health Group in the School of Hygiene and Tropical Medicine. Okay, so this work is inspired by the Global Burden of Disease project. So there are various global burden of disease projects. The one that I'm presenting figures for here are from the World Health Organization. And that estimates that the global burden of disease associated with inadequate WASH, so that's inadequate access to and use of water supply, hygiene and sanitation, that is estimated to lead to around 1.5 million deaths every single year, around half of which are due to diarrhea, and around a quarter are due to respiratory infections like flu, pneumonia. And it's worth pointing out that that's 800 dead under fives every single day. So we can imagine the personal tragedy involved in every single one of those deaths. And so if we dig down into how the global burden of disease, excuse me, is calculated, it takes the form of DALYs, that's disability adjusted life years. And the DALYs are calculated based on the years of life lost relating to a particular exposure or lack of exposure to a WASH condition, plus the years living with disability. Now, in the case of the two diseases I'm going to be focusing on, which are respiratory infection and diarrhea, these are mainly diseases which affect children, and particularly under fives. So when we work out the calculations for the numbers of DALYs, they're heavily weighted towards years of life lost, and that's because the years of life lost calculation it factors in the total number of deaths multiplied by the life expectancy at that age. And so for children, you'd expect that to be much greater than it would be for older people. At the same time, the years living with disability tend to be quite low, because even generally we're talking about endemic circumstances. So we're not generally talking about epidemics. We're living through an epidemic, but the more normal condition is endemic conditions. And in those circumstances, we might expect, for example, for diarrhea, around 3 cases per year per child. So what it out is that for diarrhea, the years of life lost account for 90% of the total numbers of DALYs lost. And for respiratory infection, it's more like 99%. So it really is important that this mortality due to these diseases is really the crucial thing that we're interested in and that policymakers are interested in. Okay, so what are some of the problems with I'll talk about a evidence gap map in WASH that we've just published in the last week. And we estimate that there are over 350 studies that look at the impacts of WASH improvements in low and middle income countries. And there are quite a lot of systematic reviews of that evidence. And so many of the systematic reviews focus on diarrhea morbidity. So that's children's carers reporting how diarrhea has changed for the children that they care for over the study period. So what are the problems with that evidence? Well, first of all, it's indirect because the evidence is based on morbidity, whereas, as I've just explained, it's mortality, which is the primary outcome we're interested in for policy. And so that there's an assumption there that the morbidity accurately reflects mortality or is closely correlated with it. And second of all, there are known problems with reporting of disease. So it says here participant fatigue and survey effects. Someone memorably also called it the bugger off effect, which is essentially that in a trial situation, particularly when there's multiple follow-up periods, children's carers, they get tired of the surveyors coming around and asking them about their children's health, and so in the end you see reductions in reported morbidity in both treatment and control groups, or the bugger off effect. And all of the existing WASH systematic reviews, including those that make up that underlie the WHO's global burden of disease, are based on trials that report morbidity. But on the other hand, and there are good reasons why those trials focus on morbidity rather than mortality. The first one is statistical power. So mortality is an even rarer outcome than morbidity. So it's harder to assess, and it may just simply be impossible for a standard trial to reach the numbers of participants required to statistically estimate effects on mortality. But also there are ethical issues with measuring mortality when life-saving ORS, oral rehydration solution, is known to be effective, and it's also very cheap to provide. Okay, so what are the two solutions that I'm aware of that could be used to overcome this problem? So the first one is the one that the WHO have used, which is a method proposed by Paul Hunter, which is to use Bayesian statistics to adjust for biases in reporting. The other one, which is the method that we're proposing in this paper, is to go the direct route and to incorporate and synthesize evidence on mortality. And there's a really good reason for doing that, which is that mortality is known to be less susceptible to reporting bias, and particularly all-cause mortality. So it seems that people, when you ask them whether their children have died, they don't lie about that, or they don't misreport that, whereas they may have incentives, or it may be permissible to report information about whether their children have simply suffered a disease. But as I've explained, and I'll come on to talk about in the next slide, there are challenges in doing that, and so we really need to utilize the greatest statistical power of meta-analysis in order to go about doing that. Okay, so here is an example of a source of data on mortality in trials. So this is, I'm sorry if it's not very large, the type in this presents a participant flow diagram. Now, according to Consort, which is the first came out in the late 1990s, all trials should report their participant flows, and that's the participant flow that from when the sample is being selected through to the randomization approach, through to the follow-up surveys, and this information should be reported by numbers in each of the trial groups, whether they're treatment or multiple treatment and in control groups, and the reasons for dropouts, so losses to follow-up or attrition, should be given in those trials. So this is a Consort diagram from a study in South Africa. Yes. So essentially, the bit that you can't see, which is covered by this figure here, is essentially the bit that tells us what the losses are to follow up in terms of numbers of people that have dropped out and what are the reasons, and the reasons include that the child has died. So as I said, there are some issues with doing this. So if we take the data from this study in South Africa and we just calculate the effect in terms of numbers of deaths amongst children in the treatment group compared to the control group, and then we plot them in a forest plot, which is this figure shown here, what you're seeing is that there's at least for the first line, which is for people living in formal dwellings that were provided improved wash services, there is a significant there is a reduction in mortality as measured by the dot as shown by the dot, which is below the point of no effect. But it's highly statistically insignificant. So in fact, it's so insignificant that the confidence interval, it not only overlaps the null effect, which is this vertical line of 1, because it's a ratio estimate, it also almost overlaps with 0, and it exceeds 630. So this is a very highly insignificant effect. So in other words, we're going to need a lot of studies in order to do something statistically meaningful with this data. So the good thing is that we did a WASH evidence and gap map. That study's been published in Campbell Systematic Reviews in literally, I think, last Monday. And that's WASH evidence and gap map collected all the evidence on promotion of water sanitation and hygiene in households, communities, schools and health facilities. And it looked at the different types of interventions that may be used to promote WASH technologies. And it also looked at a range of outcomes, both behavioural and health related and socioeconomic. And we specifically also collected data on mortality. So we had a pool of intervention studies from which to draw from. And so another example from this synthesis, I believe, is that we can use evidence gap maps to undertake much of the searching, so that then we can do our meta-analysis and come up with our policy implications more quickly. So this is the actual study search flow. It wasn't quite as simple as just extracting the data from the included studies. We did need to do some additional searches, and we've ended up with 54 included studies, of which around 80 measured all-cause mortality and 17 measured diarrhea mortality. So that's the diarrhea mortality is studies that have assessed mortality due to diarrhea using verbal autopsy, largely. So here's the forest plot. So this is the forest. I'm going to present two forest plots. One is for all-cause mortality, which is this one here. And this shows the all-cause mortality from around 40 studies. And what you can see, what I'm directing your attention to at the bottom is this. It's difficult to make out because it's very statistically precisely estimated, but it's supposed to be a diamond in the bottom. And what this diamond shows is the pooled effect. So in other words, when we look across all of these studies, all of these 40 studies, only one of which is individually statistically significant. What we find when we use meta-analysis is around a 15% reduction in all-cause mortality. Second of all, what happens when we just synthesize the evidence on diarrhea mortality? So again, we have fewer studies this time. We have around nine or 10 studies. But what do we find? We find around a 50% reduction in diarrhea mortality. And again, only 2 of the studies are individually statistically powered, but when we use the greater power of meta-analysis, we can estimate statistically precise effects. And even one of the interventions here, which is an intervention which looked at hygiene in Pakistan, that was provided in a context. So you see that there's the effect appears to be perverse, and the context in which this hygiene was provided was that households were given hygiene promotion where there were only 2 hours of running water available to at the community taps per week. So it's a questionable instance of where, in order for hygiene to be effective, there needs to be sufficient quantities of water to enable people to wash their hands and to wash vegetables and wash other things in the household. Okay, so why, in addition to the theoretical or in addition to what is known about mortality being a less biased reported outcome, what other evidence supports the veracity of these findings? Well, first of all, we looked at publication bias. Now, it is very rare, but publication bias is a problem which is known to affect all types of academic literature. I'm not aware of a field that is not affected by publication bias, and that includes the field of studies which look at the reporting of diarrhea outcomes, for example, diarrheal disease outcomes. So when we look at these funnel graphs, what we're looking for in a funnel graph is essentially lack of we're looking for lack of synchronicity across the diagram. So in other words, when we plot a line which a regression line of the relationship between the effect size and the standard error, if that effect size comes up through the center of the graph, as in the case on the left, then there is no evidence for publication bias due to small study effects. And so you see in this case that for the all-cause mortality outcome, there's just no evidence for publication bias. And that's, that would make sense given that all of the studies, given that we've harvested the data from the the participant flow diagrams. So that in fact, the studies that report the participant flows already have better reporting. So this is a good case where we're not seeing publication bias by definition. And it's a similar case for diarrhea mortality, although it's a less strong relationship, and we don't have as large a sample size. We also conducted a negative control or a placebo group analysis. Essentially, diarrhea and respiratory infection, they kill under fives, but those people that are able to develop immunity don't tend to die. Now, of course, we're going through a COVID pandemic, so we're under a different circumstance, but generally these diseases kill children. And what we're finding here is when we meta-analyze those estimates, which are from children aged over 5 and in the adult population, we're not seeing any effect when we look across studies. Kerry, how much? I think have I got a couple of minutes?
You do, Hugh.
Yeah. Okay. Thank you. Yeah. So we've done some meta-regression analysis using a general to specific methodology. And we're able to explain quite a large proportion of the heterogeneity in findings. There is very low heterogeneity, but there is some, so we've tried to explain that. For the all-cause mortality, a lot of the variation, at least in terms of WASH interventions, comes from provision of hygiene. So hygiene, when it's provided alongside circumstances where there is an improved water supply, we get significant effects on reducing mortality. And there's some, albeit smaller, but also statistically significant finding for sanitation. When we focus on the diarrhea mortality, and we have a much smaller sample, so our statistical power is much lower, what we're seeing is that the effects seem to be explained entirely, or the effects of the WASH interventions are explained by the provision of community-wide sanitation. So that's that's providing latrines to an entire community rather than just household by household, and it may use a promotional strategy like community-led total sanitation. So this is also quite consistent with what the theory would say, because diarrhea mortality, all-cause mortality, it incorporates diarrhea mortality, but it also includes mortality due to respiratory illnesses and other factors. And so we know that one of the main ways of stopping transmission of respiratory infection is through better hand hygiene, or is partly through better hand hygiene. So we would expect to see the findings for hygiene to be more prominent for all-cause mortality than for diarrhea mortality. As a kind of couple of last slides, first of all, we updated the global burden of disease estimates, and what we estimated was that the current existing global burden of disease, which is based on systematic reviews and meta-analysis of morbidity, is underestimating the annual deaths due to WASH by somewhere in the region of 500,000 to just over 1.5 million people, and a lot of that is due to is people living in the Africa region. So what are the implications for research? So in addition to the implications for doing synthesis work, there's some important implications of reporting of trials. So this figure shows the studies, and I'm sorry that I'm not sorry, but I'm differentiating studies published in environmental health from studies published in economics. And what you're seeing over time is those trials where participant flow diagrams are presented, but as a share of the total numbers of trials presented. So you're seeing that there has been an improvement, at least in environmental health, of reporting of participant flows since the consort guidance was originally presented in 1998. But we're just not seeing that in economics yet. In fact, there are only 2 trials that have either presented a participant flow or that have presented the information from which we can estimate losses to, we can estimate the information that we need in order to do this meta-analysis. I know there are reasons why in economics, the data are published generally by journals freely, so it is possible to go back through the data, but this really is a plea to everybody working in WASH trials research to report your participant flows. So there you go. So thanks very much, and I'm happy to hear some comments and questions.
Thank you very much, Hugh. Fantastic. So we've got about 15 minutes or so for questions for both speakers. Please go ahead, for people that maybe haven't had a chance to think yet, to start typing in some comments or questions for Hugh. We've had a couple of questions that have come in from Monica. So the first one is actually from my colleague, Shivit Pokrania at UNICEF, who says, thanks, Monica. Did you find studies with a participatory research design that spoke to your point on community involvement in design? And was this evidence considered in your study inclusion criteria?
So thanks, Shivit, for the great question. We did start with actually, IAP2 participatory spectrum, as a community engagement framework. But when we actually looked at the literature, the studies, the way the interventions have been designed is not according to that spectrum where, the community, there is a spectrum of community involvement. But the way that they have been done is actually, there has been a recent systematic review, which was very nice to see. It's a more a utilitarian concept of community engagement, where the implementing agencies or the policymakers realize that they want to engage communities not because of the social justice perspective that is taken by participatory research, but rather, or participatory interventions, but rather by that, if we engage communities, it would lead to better results. But the interventions themselves are actually implemented and delivered in the frameworks that the other interventions are also delivered. In short, if there is a participatory research design, and it is actually it falls into any one of the engagement types, it will be included, and it's most likely going to be because in participatory research, if there was a self-help group formed or a community health worker, a cadre of community health worker formed, then that would get included into our engagement type, which is engagement as the intervention.
Thanks, Monica. And there's a follow-up question, actually. Bear with me, I'm just finding it.
Yeah,
can you read that? Yeah. So he also says, when you're looking at how did you go about actually finding qualitative studies that spoke to design and fidelity issues, and was that difficult? For example, finding policy or programming documentation that included this evidence.
It was quite difficult.
Yeah.
Not surprisingly, I think we spent a lot of time looking for studies. We looked at trial registries to see for any of these studies which have been registered, are there any additional documentation? Because sometimes the qualitative studies or project documents get registered, they also show up in those trial registries. We also actually search for the interventions themselves, which have been evaluated. But we had to make sure that the period period is the same as the study period. So there was a lot of details or a lot of care that was taken to make sure that whatever project documents we receive are associated with the intervention in question that has been evaluated. It was so difficult that I think it's 17 of the 61 studies where we actually found a lot of documentation. And then for most of our evidence, or not most, I would say, but a big chunk, we actually could not find a lot of associated documentation. And most likely it is not because we were not able to find it, it's because it doesn't exist. At least it doesn't exist in the published form. It may exist in some, book stacks of authors, but it does not exist in published form on the internet. So it was difficult.
Yeah, I can imagine.
Yeah.
So I can see my UNICEF colleagues are very active today. Also, Camila Pereira is asking Hugh a question saying, fantastic work, Hugh. Very impressive differences with previous WASH death estimates. Do you suspect underreporting of mortality and or morbidity, and how more generally, I guess, do we manage such underreporting in similar meta-analyses?
Okay, thanks, Camilla. Yeah, I mean, I'm glad you've raised this point about the differences with previous WASH estimates, and it's worth saying that current WHO estimates they use a bias correction factor that don't estimate any effects of hygiene. So under the current WHO global burden of disease meta-analysis and the calculations, there is no impact of hygiene improvements. And so what we're showing here is that not only is there a significant effect of hygiene interventions, but at least for all-cause mortality, hygiene is the most important is the most important intervention. But it's really important that the water supply is available in order for people to be able to practice improved hygiene. So on your question about underreporting, as I said, we don't suspect there is underreporting of mortality because intuitively, but also meta-epidemiological evidence suggests that people just don't lie about they don't misreport whether their children have died. The difference, so it's a major difference with the evidence on reporting of morbidity, which there is very likely to be underreported morbidity. So I mentioned this fated bugger off effect, whereby people they just get tired of it's quite a lot of work to engage with long surveys, and if you're being surveyed multiple times a week, there's opportunity costs of time for survey respondents, and so a lot of these studies were seeing reductions in reported disease rate in both treatment and control groups, of which the reason for that seemed to be that it was a underreporting of morbidity. So I hope that just to add that so I presented findings from both all-cause mortality and cause-specific mortality relating to diarrhea. So the meta-epidemiological evidence suggests that all-cause mortality is unbiased, but it isn't so clear-cut for the diarrhea mortality. At least when studies use verbal autopsy, people might, when they're asked if their child's died, if they're asked for the reasons why, they might be able to associate that with the symptoms of diarrhea for a WASH study, for example. But it's certainly the evidence also indicates that it's still less biased than reporting disease.
Thanks, Hugh. There are no more questions in the chat for a minute, but I have a question that I wanted to ask you. So I was quite struck by, what you were saying about participant flows, and wondering what do we have to do to encourage better reporting of that? And also struck by the fact that the environmental health community seems to have got its act together a lot better than economists. So I mean, I was interested in that, and kind of what your reflections on that are, why that might be, why the difference, and what we could do in all communities beyond environmental health and economists to get better at doing this.
Yes, it's a really good question and something we're wrestling with at the moment. I'm not sure whether we're quite at the name and shame stage yet.
but you just did.
Well, no, I'm not. We're not shaming individual. We're not shaming individual authors at this point.
Yeah.
So I think what do we need to do? So there are standards of reporting, and those standards will be different across different disciplines. And so what is the, as I talked about in the presentation, that there are reasons why economics journals will publish the data so the studies can be replicated at the push of a button if you can download the data and the file in order to do the estimation. So in some sense, the economists are already providing those data, but at the same time, when for people working in synthesis or people working in policy, they don't really have the time to download every single data set in order to obtain the losses to follow up and then do this kind of work. So one plea would be simply that can those studies, and can there be better standards promoted by journal editors to report these study flow diagrams. And the participant flows, they're not only important for this kind of work, they're also important in particularly in cluster trials for assessing selection bias. So it is really important that the participant flows are reported. More generally, it's a question about incentives, and I think that we need we are working on a project where we are trying to pull together an author collaborative where we work with authors of studies to obtain the participant flows and the individual participant data in order that we can do the work in a more complete way, because the data is selected. It's selected from those studies which reported it. So any additional estimate gives us more statistical power and more precision.
Thank you, Hugh. We have 3 minutes left. I have so many questions I want to ask both of you, but I will have to follow up separately. But I wanted to give you both an opportunity to, as we close out, to share some of your key messages. So either for the evidence synthesis community, I mean, I think a lot of methodological challenges came up in both of your presentations, but also for policymakers about how they need to think or act differently, or indeed implementers, particularly for Monica. So Monica, over to you, your key messages for the synthesis and the policymaking communities.
I think the key message would be that, the community engagement interventions, especially with COVID, have really come into prominence. And there has always been a question whether they're effective or not. I think the key message is they are effective. I think what we need to think more is, and we did find that, the certain types are more effective than the others. I think, but there was also a problem of reporting, because the way they were reported, we started, as I was, in response to Shivit's question, we started with one framework and we had to basically abandon it. And the reason was that the way that the interventions have been implemented are completely differently. And then the way they've been reported is then even a smaller part of the way that they have been implemented. So I feel community engagement are effective, and then just for general researchers and policymakers, I think it would be great to have better reporting of these interventions to be able to assess what exactly what kind of community engagement was it that led to that positive change.
Yeah, fantastic. And it's spun loads of thoughts for me around the community engagement mechanisms versus the more behavioral insights, individual mechanisms and effectiveness, etc. But we'll come back to that another time. Hugh, the last minute is yours.
Okay. So I would say for those working in research synthesis, we always say that critical appraisal is important, so risk of bias assessment. I really think we need to be more cognizant of biases in when outcomes are reported. Lots of outcomes get reported, and there may be incentives to either underreport or overreport the incidence of those outcomes. But we need to be I think we need to be more serious about how we incorporate that bias into both our critical appraisals and to the synthesis method, the synthesis that we do. For the policymakers, I think the finding for hygiene is quite clear. So hygiene really does make a difference to whether children survive to the age of 5. But I think more for those people that work in policy that are commissioning research, I'd say a couple of things. The first one is that starting with an evidence map can make a really big difference to the quality of the synthesis that ends up being doing, because the synthesis ends up answering a relevant question relating to a known gap in the field. So it's a really important start for doing evidence synthesis. The other thing I would say is that as we're doing more complex meta-analyses, we need to start drawing on more individual participant data meta-analyses, which is a bit more resource intensive. So and that rigorous work needs to be factored into study budgets and what commissioners are prepared to support.
Brilliant. I'm going to draw us to a close there because we're already at time. Thank you so much, Monica and Hugh, for your really fascinating presentations today. And thank you, everybody, for joining us. And see you in some of the other sessions. Bye-bye.
Yeah. Thanks a lot.
Thank you. Bye.
Bye, Kerry. Bye, Hugh.
Thanks, Kerry. Bye, Monica. Thanks.
Bye.